Thank you so much, Dr. Saad Mahdy. Thanks, Larry, for inviting me to such a great course. I would like to express my thanks, my great thanks to Dr. Saad Mahdy for such invaluable course. And it has been really very, very helpful to everyone, exam attendees and the clinician. And it is really very, very outstanding. And tonight is really a special night. So first of all, I would like to welcome you all on board, all the audience. Thank you so much for your time. Thanks for coming and joining the course tonight. It is a great pleasure and a chance to meet the expert today in ultrasound. So as you know, as time progresses, it has been very, very challenging and dynamic in ICU, and we would like every new technology to help us to diagnose and to treat our patient in very, very timely fashion. So it is the time for ultrasound, which lead to the death of X-ray at least, and I'm expect more of our investigation examination will be dying soon in the future with the use of ultrasound. It is my pleasure and honor to introduce Dr. Walid Shibl. He is senior ICU consultant for more than 20 years. He worked in Egypt and in Saudi Arabia. Currently, he's in Egypt. He is ICU senior consultant in the Mahdy Medical Complex. Dr. Walid Shibl had plenty of qualification, MRCP from UK, special certificate exam in acute medicine, and I was honored. I went to the exam of European Diploma of Intensive Care with Dr. Walid Shibl with him there. I still remember really very, very nice pleasure time. And Dr. Walid Shibl also has plenty of certification in ultrasound. He's teaching ultrasound not only in theory, not only online, but he teaches bedside. And he had a clinical examination, which is European Diploma of Echocardiography. As you know, this exam has two parts. The first part, which is in theory exam, which is MCQ, which is the knowledge exam. And then he finished his logbook, and all the logbook of Dr. Walid is in his YouTube channel. So it is a very, very good chance for all of you. I advise very, very strongly for all of you to visit the YouTube channel of Dr. Walid Shibl to learn more about ultrasound, how it can save you in our patient with challenging disease and different expected complication nowadays with the progress of the disease, especially COVID and other implications. So Dr. Walid Shibl is going to talk to us tonight about using ultrasound to differentiate between cardiogenic and non-cardiogenic pulmonary edema. It is really a very, very interesting topic. I advise all of you really to focus and concentrate with Dr. Walid Shibl. And kindly ask all the panel members to switch their camera and mic off. Please, Dr. Walid, go ahead. Thank you so much.
Yes. Thank you a lot, Dr. Amr, for this kind introduction. And thank you, Dr. Saad and the organizing committee to give me the opportunity to be with you this night. And I hope to teach each other and learn from each other in this webinar, inshallah. I will share the screen. Okay. Is it clear? Sound clear, Dr. Amr?
Yes, we can see the screen and sound clear. Go ahead, please. Thank you so much.
Yes, thank you. My lecture today is about how to differentiate between cardiogenic and non-cardiogenic pulmonary edema by lung ultrasound. Objective use of lung ultrasound to differentiate between cardiogenic and non-cardiogenic pulmonary edema. Let us talk about this lady, 67 years old female patient, known case of ischemic heart disease, long-standing diabetes mellitus with diabetic nephropathy, admitted to ICU after right side balloon amputation. She has oliguria over the previous few days, severe respiratory distress with O2 saturation 91 on 15-liter non-breathing mass, tachycardic, normotensive, a lot of crackle all over the chest, lax abdomen. Chemistry, increased CK, mainly muscles, LDH, high LDH, neutrophil leukocytosis, anemic, hemoglobin is 8, creatinine 3.4, urea 100 milligram per deciliter. And this is the X-ray. Cardiogenic or non-cardiogenic, this is really a problem. This X-ray, you can translate it to a lot of disease. Let us talk about lung ultrasound. I'm sure all of you know the normal lung ultrasound, which is the repeated transverse line, A line. And this A line, really, the physical basis for this A lines is that the pleura is the surface which separate the muscle and soft tissue and the air in the lung. And any interface between tissue which too much different in density, like muscle or soft tissue and the air in the lung, this interface will be so reflective. It reflects all the ultrasound beam. So the probe here will emit ultrasound, will hit the pleura and come back to the probe, and will emit the pleura, will come back again, and this will be repeated and will give this very wide echogenic transverse line of the pleura, which is a very good reflector because of the difference in density between the muscles and the air in the lung. And you will not see air in the lung. This is the normal lung ultrasound. It is repeated transverse line, as you see, and this transverse line associated with sliding of the parietal pleura and visceral pleura. This is the normal lung. This international evidence-based recommendation for point-of-care ultrasound, which published in Intensive Care Journal 2012, talk about the pulmonary edema or interstitial syndrome. And they describe what's called B line instead of normal A line in the aerated lung. They describe B line as a hallmark of interstitial syndrome, and described as laser-like, arrow-like lines originate from the pleura and move with breathing with the pleura and reach to the bottom of the screen. And in their recommendation, this international evidence-based guidelines, in the very strong recommendation, level A, which is multiple B line are the sonographic sign of lung interstitial syndrome. And you can consider this B line as a careless B line. So, the normal lung is the A line, which is the aerated lung, and the pulmonary edema or interstitial syndrome is the B line. A line and B line. In this great book of Critical Care Ultrasound by Professor Philip Lam and Demetrius, they give a chapter about acute respiratory distress syndrome versus acute cardiogenic pulmonary edema, differential diagnosed by lung ultrasound, and they rely on the differentiation between cardiogenic pulmonary edema and ARDS on the article by the Kubiti et al., which published in 2018. And this is the result of the article of the Kubiti, Professor Kubiti. As you see here, unfortunately, B line is present 100% of time in ARDS and in 100% of time in acute cardiopulmonary edema. The B line per se cannot differentiate between cardiogenic and non-cardiogenic pulmonary edema, unfortunately, but he relies on several other factors and the ultrasonographic pictures and views in the lung and the pleura to differentiate between ARDS and acute cardiopulmonary edema, like spared area, consolidation, pleural line abnormality, lung pulse, pleural effusion. Let us take each one of these factors in some details. Moreover, the same international evidence-based recommendation for point-of-care ultrasound reached the same conclusion with a strong recommendation. They reached to, in contrast to cardiogenic pulmonary edema, the sonographic finding indicative of acute respiratory syndrome include the same pleural, subpleural consolidation, abscess of lung sliding, spared area, pleural abnormality. Let us see what is going on. Very simply, the pulmonary edema of cardiogenic origin is due to congestion with transudative type fluid. So you will not expect signs of inflammation in the lung and the pleura. But the pulmonary edema of non-cardiogenic origin, like chest infection, lung trauma, contusions, trali, all these inflammatory states will lead to inflammation with leaky alveolo-capillary membrane, so you can expect signs of inflammation in the lung and the pleura. So, very simply, to differentiate between cardiogenic and non-cardiogenic pulmonary edema, you need to look for signs of inflammation. Let us take all these parameters of differentiation piece by piece and analyze it. First, the concept of lung water. This is the A line, which is grade 1 lung water, fully aerated lung. If you see some B lines in the screen, but not all the screen is B line, this is non-confluent B line, grade 1 lung water. If you see a lot of B line like a curtain covering all the screen, this is a confluent B line, grade 2 lung water. If you see consolidation or hepatization, the lung became like the liver. This means all the alveoli are filled with fluids, and this is the grade 3 lung water. And from this first concept of lung water, we can differentiate between cardiogenic and non-cardiogenic by looking for consolidation, as in Coviti and Coviti et al. Differentiation, great publication. Consolidation is very common in ARDS and not present in acute cardiogenic pulmonary edema. So, number one, to differentiate between cardiogenic and non-cardiogenic pulmonary edema, you need to search for consolidation, which is present in ARDS but not in acute cardiogenic pulmonary edema. Second, as we just said, concept of pleuropulmonary inflammation. ARDS, most causes of ARDS and non-cardiogenic pulmonary edema will lead to inflammation in the lung and the pleura. So you should reach and search for signs of inflammation in the pleura and in the lung. Look for this pleura by high frequency probe. This pleura is irregular, and below the pleura is what's called subpleural consolidation, very dirty consolidation with irregular surface, which is denoting inflammation in this area. At the same time, you can see the sliding is poor sliding because of sticky pleura due to inflammation. But if you look for this patient with thin, smooth pleura and moving, sliding in proper way, because this patient has transudative cardiogenic pulmonary edema and this patient has inflammatory pulmonary edema. Look again for this dirty pleura with very poor sliding and subpleural consolidation, dirty pleura, poor sliding, and very good sliding and smooth pleura of cardiogenic and non-cardiogenic pulmonary edema. Look for this subpleural consolidation and dense P-line and very thin pleura without subpleural consolidation, without any irregularity, and very good movement because of no good sliding because it is transudative effusion, but here it's sticky pleura with very bad sliding and subpleural consolidation. Back to the great Coviti article. Pleural line abnormality is present 100% of time in ARDS, but only 25% in acute cardiogenic pulmonary edema. And this was maybe because of old fibrosis, fibrotic and adhesion in the pleura. But this frank picture really of subpleural consolidation, bad sliding, dirty pleura, this really, I have hundreds of cases. This denoting ARDS. But this 25% in acute cardiogenic, this is probably due to old thing like adhesion in the pleura. Third, the concept of increased wedge pressure in congestion. Why there is pulmonary edema in congestion? Because there is increase in left atrial pressure, which will lead to increase in pulmonary venous pressure, increase in wedge pressure, and this will lead to flooding of transudate in the alveoli, in the interstitium of the lung. So the process of cardiogenic pulmonary edema, it is a diffuse process because this increased pressure will affect all the area homogeneously. But In contrast to non-cardiogenic, which is the patchy inflammations, you will expect to see patchy distribution of the lesion instead of homogeneous distribution. Let us see this patient with cardiogenic pulmonary edema, smooth pleura, all the area which I examine here, I revealed B line because it's homogeneous B line because the process is a diffuse, is increased pressure. But for this patient, it is inflammatory patchy process. So you will see B line and A line, B line and A line in the same area. You will see A line and B line in the same area because it is inflammatory patchy process. Look for this A line and B line. A line and B line in the same area. This really, look here, this spurred area, patchy inflammation is 100% specific and sensitive for ARDS. And it is not present at all in acute cardiac pulmonary edema. So look for these details because at the end of the day, you will diagnose by this picture. Because if you take, we can discuss a lot of differentiation, but please look for these details in the pleura and in the area, and it's very important. Fourth, right side pleural effusion. As you all of you know, heart failure with increased transudation will lead to right side pleural effusion. Because of that, the OBT found this is right pleural effusion. This is the spine side of pleural effusion because the spine appear clear because there's fluids here. And OBT found that pleural effusion is common in acute cardiac pulmonary edema compared to ARDS. But as you see here, if you look for the pleural abnormality and the spurred area, it is really a differentiating because there is much discrepancy between cardiogenic and non-cardiogenic. But pleural effusion, it is very minimal. You can hardly you can differentiate between 95 and 66. Fifth, lung pulse, and this is related to consolidation. If there is consolidation, you can transfer the cardiac pulsation very easy. And as we said, consolidation is common in non-cardiac pulmonary edema and lung pulsation is common in non-cardiac pulmonary edema. But I will repeat again, according to the COBT, it is present here in 50% sensitive, 100 specific, and it's specific 50% for acute cardiogenic. So I will repeat again, look for the pleura, sliding of the pleura, subpleural consolidation, irregular dirty pleura, spurred area. This is really the differentiation. Back to our patient. Cardiogenic or non-cardiogenic, this is the problem. We dissect the lung by ultrasound to know each opacity, what can mean each opacity of these lot of opacity in the lung. We will dissect the lung now by ultrasound. We'll go all around the lung, all around to know exactly what is going on in this white lung. This is the left upper loop subpleural consolidation with dense B line. So here in this area, there is inflammation. There is left lower loop consolidation with air bronchogram. So in this area, there is inflammation. There is pleural effusion left side, and here is pleural effusion. There is dense B line without subpleural consolidation in the right upper lung zone in this area, which is going with congestion. There is right side pleural effusion, which is going with congestion. Amazingly, right side cardiogenic pulmonary edema with left side pneumonia, and believe me, this is a real medicine. Chest infection precipitating cardiogenic asthma. Patient was connected to mechanical ventilator with adequate PEEP. A trial of high dose Lasix was given while preparing for dialysis. Next day, you see the cardiogenic pulmonary edema cleared, but the non-cardiogenic pulmonary edema appear as standalone opacity here, which is very clear pneumonia. And when we did lung ultrasound, this is the left side is still subpleural consolidation with B line, but right side became A line. Conclusion. B line is the hallmark of pulmonary edema. B line are present in 100% of patients with cardiogenic and non-cardiogenic pulmonary edema. It is 100% non-specific. Look for heterogeneous B line, dirty B line, poor sliding because of sticky pleura, subpleural consolidation. If present, it is non-cardiogenic pulmonary edema. Look for homogeneous B line, good sliding, clean pleura, right side pleural effusion. If present, it's going with cardiogenic pulmonary edema. Thank you a lot. And this is website, my YouTube channel, and this is my Facebook page. There is hundreds of cases of lung ultrasound. There is real cases. There is 100 protocol for lung ultrasound. I will be very pleased if you visit my channels and comment on my work. Thank you a lot. Thank you, Dr. Saad, and I would be happy to receive any questions. Thank you.
Thank you so much, Dr. Walid. Really very, very interesting as expected and very, very informative talk. I like the way you conduct your presentation. You have already a live case, which you are involved in its management, that is well supported with evidence, which is up to date. Thank you so much for sharing that with us. Really very, very beneficial. Dr. Walid, regarding the patient who had a COVID, ARDS secondary to COVID, do you have any different ultrasound finding from your experience? I know it is area still of progressing with the research.
I have two case report for COVID, and I have my library 100 of cases really. It's very good questions. I thank you, Dr. Amr, a lot. You raise this point because it's very important. Please, my dear colleague, COVID is not one disease, please. Believe me, COVID is not one disease. COVID is 4 diseases. The difference between the COVID and the ARDS of the COVID and the ARDS of H1N1 by histopathology in the article New England Journal of Medicine, COVID ARDS has 9 times in situ thrombosis compared to H1N1. This is one element. Number 2, there is 2 different types of COVID. Please, all the COVID you face in ICU on admission, especially L type with low elastance and very good compliance, these patients usually are hypovolemic. And when you connect to mechanical ventilation, post-pressure ventilation, and give people, patient hypovolemic, this will lead the patient to collapse. So number 1, for all newcomers, please check for kissing heart, narrow inferior vena cava, and if narrow, give fluids. This is the number 1 you need to take care of. Give fluids for newcomer because they are tachypnic, they have diarrhea, they have fever. Most of them have some stress diabetes with polyuria, but they mostly are hypovolemic. Number 2, you need to look first if the lung, there is a lot of inflammation in the lung, lot of consolidation, P line. That means it is a low type, low elastance. It is high type, sorry, high elastance. You can think of recruitment. ABRV is very important. High beats, you can think of recruitment and the bronch position. But if you find the patient low happy hypoxia, too much desaturated, and you search with the lung, clear lung, batches of B lines not explaining this dyspnea, think about in situ thrombosis. And in this situation, you need to give full dose of anti-inflammatory and anticoagulant, and some people used low dose thrombolysis to clear the pathway. And the 4th pathology, I talk about hypovolemia, corrected please, corrected if you find it corrected, because this improves perfusion of the lung and improve hypoxia. Number 2, sticky lung, ABRV and the bronch position and good beep. Number 3, lung is clear and severe hypoxia, you think of in situ thrombosis, you will give anticoagulant, anti-inflammatory, and search for pulmonary emboli. This is the last one. Because some people has pulmonary emboli and needs thrombolysis. It's not lung who is hypoxic because he has pulmonary emboli. So please, COVID is 4 disease. It's not 1 disease. It's not ARDS. It's 4 disease. And I have a protocol in my channel protocol for hypoxia and COVID, I explain in cases all these in detail, all these 4 categories, because I believe it's very important to take care during the management of COVID. Thank you, Dr.
Very well. Thank you so much. That's very, very informative answer. Thank you. The other point, Dr. Walid, like in ICU, it is different, very, very, usually very, very challenging cases, and it is not only one disease. And many times we admit a patient with septic shock, and as you know, part of septic shock is septic-induced myocardial infarction. And those patients usually they presented, they could be dry initially and give them fluids. And then my question is that, is there any cases you came across that you have a patient who initially came with very, very typical ultrasound of infection, and later on this patient developed pulmonary edema, probably related to our fluid you are giving in ICU, or probably secondary to myocardial dysfunction, which is septic and sepsis induced?
It is very good questions, but now we need to differentiate between the intensivist and the cardiologist. A cardiologist is looking for structure, is looking for ejection fraction. Intensivist, and you are echocardiographer, and you are hemodynamic guy, Dr. Amr. We are concerning by the ejection fraction, not ejection fraction, we concerned by wage pressure, congestion, and stroke volume. This is what I'm concerned. In the ICU, this is what I will check. The patient may have no ejection fraction but dry, and in this situation, I can give many boluses and follow up the stroke volume and wedge pressure and lung water, and the patient will benefit. We are not concerned by ejection fraction. We are searching for, and even the patient has depressed ejection fraction or heart failure, there is very clear recommendation from the American Society of Echocardiography and the European Association of Cardiovascular Imaging said that in this patient with heart failure, if the E wave in mitral valve inflow, if the E wave is more than double the A wave, this patient has a restricted pattern and they need to deal with the patient. But if the E wave is smaller than the A wave and less than 50 centimeters per second, that means the patient has grade 1 diastolic dysfunction with low left atrial pressure. And in this situation, I can give boluses of fluids, but watch fluids, because you need not to give fluids and follow the fluids by wedge pressure, by stroke volume, and by lung water.
Thank you so much, Dr. Walid. It's really very, very important point made here that it's really our patient is dynamic, and the repeat of exam is very, very crucial to guide the management. Thank you so much. That's really very helpful. There is another question. So I think it is very clear from what you said. It is very, very easy to use a lung ultrasound to guide the treatment in ICU, and I'm sure it is very easy to our attendees to learn and start to practice. I have a question here from Sam Zaki, who's asking the type of the probe you are using in lung ultrasound, and probably if you can also give us tips about the examination area and the lung and the blow protocol, whatever your advice as expert in this field.
I use phase array probe. And you need to adjust your probe, the frequency of the probe and the depth you need. I will publish online course of lung ultrasound with volunteer, and I will clarify all these points here. But I use phase array probe because it's a small footprint and can you manipulate very clearly between the ribs. As regard the blue protocol, I prefer in diagnosis of acute respiratory failure, I have a step-by-step approach. You can, in my channel, there is very step-by-step approach for dyspnea, very simple and very crucial, because blue protocol, you can use it piece by piece. Look for sliding, look for the pneumonia, C protocol, B, and I believe you need to be expert to use it. But for me, if I face any patient, very simply, with acute respiratory failure, I will go to the inferior vena cava. If I find the inferior vena cava very narrow, that means this cause of respiratory failure is the inflammatory cause of respiratory failure. I will search for pneumonia, ARDS. If I find with this patient with hypoxia, full dilated, non-collapsing inferior vena cava, that means this hypoxia is due to cardiogenic and obstructive causes. I will go to the heart to look for the obstructive causes of hypoxia, like pulmonary embolism, and the cardiogenic causes like pulmonary edema. I have very small, very simple protocol because I don't need to take it piece by piece. I need to reach during organized pathway. But blue protocol, you can use it, but you need to be expert because you need to say everything. Pneumonia has four pictures there: COP, AP, you need to be expert really.
That's great.
But
That's really
blue protocol is great, and you can use it.
Thank you so much, Dr. That's really helpful. Samih is asking again about the megahertz. What does it mean? And he's asking also about exactly what's the linear probe. Is it the convex probe or it's different? That's what.
The megahertz is a million cycle per second. We are with the measure of frequency of the probe. It's by million. Megahertz is million cycle per second. If the probe has high frequency, say 10 megahertz, 10 million cycle per second, that means this probe will give you very good resolution over the course of a couple of centimeters from the skin, will give you very great resolution, but this probe is weak, cannot go deep to see deep in the lung. So if you are searching for consolidation or pleural effusion or pulmonary edema, you need at least 15 centimeters. In this situation, you will use low frequency probe, which is the phase array probe or curvilinear probe, which is the abdominal probe. And this range from 2 to 4 megahertz. But if you need to dissect the pleura and to see exactly the detail of the pleura and subpleural area, you need to use the high frequency probe, which is from 7 to 12 megahertz. This is the difference between probe.
Thank you so much. Again, very, very informative answer. Dr. Shibl, the last question from myself is, I want you to give, you are the expert in this field. I want you to give a very simple, clear advice to our attendees regarding using ultrasound in ICU. Many people think it is very difficult, it's complex. I know you are in Egypt nowadays and you conducting lots of teaching, a practical session, which is bedside. So what's your advice to our attendees in order to start learning and digging and using the ultrasound in daily practice in ICU?
Really, my opinion as regards the use of ultrasound, if the ultrasound machine is present in the unit, it should be trained. The candidate should be trained if the ultrasound is present. My opinion, you can divide the ultrasound in several sections. My opinion, at least for the attendee who are working in the intensive care field and the anesthesia field, to know about the basic vascular critical care ultrasound course. They need to know the basic to how to insert the lines, arterial line, central line, peripheral line by ultrasound. This is very crucial and very important, the number one. Number two, at least need to check inferior vena cava by simple approach, because in the emergency, if the patient is hypotensive, and you saw the inferior vena cava is very narrow, you can give the order to give fluids in no time, and you can save and improve the patient until the senior will come. And if you found the same patient with hypotension with full inferior vena cava, you can start levofed. Whatever the cause of shock, it will respond to immobilizers. This is a must for the, and you can train on this inferior vena cava very easy, because we run hands-on courses. Very easy, you can learn it in a couple of minutes. It's not a problem at all. And the third is to assess for DVT, because DVT is very common in ICU. I advise all the attendee to concentrate on these 3 points. And after that, they can look for the lung. And keep the heart at the end. Don't go to the heart directly, because heart really is tricky. But at least in basic vascular at the lung, it is applicable. It is general critical care. And after that, you can go to the advanced critical care. This is, and especially if the machine is present. For all the attendee here, you are your teacher. You will teach yourself. I know Dr. Amr, he was working in military hospital in Eastern Province. He used to do ultrasound for all the patients in the intensive care, because they have 2 machines there.
Exactly. Thank you so much, Dr. Walid.
Thank
Really, very, very informative. So there's really many important points here to all of us. So learning and training is very important. Safety is an issue. We need to have a kind of formal training program. Of course, this online and YouTube channel is really very, very helpful, very important. But you need someone like Dr. Walid Shibl to organize and to teach you, conduct your training or during the progress of your career. And also you need really to be encouraged to use the machine all the time. I believe every intensive care unit should have at least one ultrasound machine. Like you could have the answer
you.
for new thorax in no time.
And
That's right.
for the interested people and for the senior people here, really, I finished the certification in European, and inshallah, I'm finishing in America because I finished all the paper, lookbook, all everything. I'm just waiting for the result of committee. For anyone who is interested for certification, I will be the one to review the lookbook. For anyone he saw himself is efficient and he can reach the level of advanced critical care ultrasound, I will be happy to be his supervisor and the mentor. And I am knowing that the EDIC will accept my supervision for his lookbook.
Thank you so much for that announcement. Really, very, very, very good offer for everyone. We don't have any excuse. So we have experts willing to help all of us. The last question here from Ram is he's asking, which ultrasound device do you recommend? Is there any machine you think is better than the other?
No, I cannot answer this question. I cannot. But you know by yourself, I know this machine is better in this area, this machine, but I cannot say that.
Sure, sure. Thank you so much, Dr. Walid. Really a pleasure and very interesting lecture as expected.
I think there is a machine which you can buy, you know.
لما هو there is too much discrepancy in the price. يعني في machine reached to millions and point of care and the machine reached to 340. You should get used on your machine. يعني. By the time you will get used on it and will get used on the image and you can adjust.
I think
very
also,
tricky questions.
yeah, and also it's very, very important to familiarize yourself with your machine. Like you can have the machine, but you don't know how to operate it properly, how to use the focus, the gain, the depth. Really, very three tips which make a huge difference, especially in our patient ICU, which most probably difficult will do, especially with mechanical ventilation. Positioning is not easy and most of times. Thank you so much, Dr. Walid. Really, very informative. Thank you so much for your time. So now I'm introducing Dr. Rabab Safwat.